One of the things I was asked to do today along the concept of really critical thinking on how we make decisions as clinicians every day in our practice, especially as it relates, of course, to aesthetic dentistry as a whole, but specifically where implants relate to it. But to try to really focus on one component of that, and that's the concept that David just mentioned, one abutment, one time. Marco De Gidi mentioned it earlier today. It's one component that we look at in terms of optimizing tissue integrity and creating a stable environment in that area. You've seen that we deal with so many different components every day. It's in implant dentistry, from the implants themselves. We talked about macrogeometry, microgeometry. But our team in Atlanta, David, Maurice, and of course Ron Goldstein, who's not here with us today, but it's a concept that's integrated in aesthetic dentistry. So we take different components, different techniques, different philosophies, and put it all into developing an aesthetic restoration or aesthetic product in the end, integrating all the elements of bone and soft tissue within the lip perimeter and as it relates to dental-facial aesthetics. So ceramics, digital technology, adhesive technology is only a piece of the puzzle. When we talk about smile design in the anterior region, you've seen beautiful examples of that today. We talk about the single unit environment in the aesthetic zone, and of course also the multiple tooth environments. Briefly, because we don't have a lot of time and I have only one concept I'd like to share with you, we try to simply break down the environments that we work in as a restorative recipient site. The type 1 site is an ideal site. The bone, the soft tissue, the space is ideal, and we try to preserve it. When we have labial defects, bone or soft tissue, that's called a type 2 site. And type 3 sites are ones that have interproximal defects. So when I talk to David, when I talk to Maurice or Ronald, and we say type 2 or type 3, everybody on the team understands that. And the goal of everything that we do is we want to, as restorative dentists, to work in type 1 sites. That's where we get the best results with our restorative dentistry, and that's where the laboratory can also give us the best work that they can do in type 1 sites. So from a philosophical standpoint, what we try to do is if we have it and identify a type 1 site, we try to preserve it. And we design therapy to preserve that type 1 site. And if we don't have it, to take type 2 sites and type 3 sites and reconstruct them into type 1 sites, and to do all of this and integrate it within an aesthetic profile and aesthetic principles that we have available to us. So most of the work that we're going to talk about today relative to one abutment, one time is really all about preservation. And this can be done if you have a type 1 site to begin with, or it can be done if you've already reconstructed a type 2 or a type 3 site into a type 1 site. And the one abutment, one time is about, as you've seen described, putting in the final abutment at the time of either placing your implant or at the time of stage 2 surgery, preferably at the time that you place implants in the type 1 site. A key factor that we all talk about is preserving the labial tissue, height, the interproximal soft tissue, the papilla. But one factor that hasn't been discussed up to now has been the issue of color. That the tissue color also has to be stable, it has to be in balance, it has to be in uniformity with the adjacent tissue. And I think those are very, very critical factors, especially when we're dealing with thin scallop periodontium. We can't take a thin scallop periodontium and make it into a thick flat. But we can take it and make it at least into thick tissue. It would be thick scallop by thinking and factoring in soft tissue grafting in our techniques. And the reason we talk a lot about this is because while we talk about implant site development, this is actually a concept that was started back in the late 80s by David Garber and Oded Bahat and others, maybe some of you in the audience, to take an area, it's a generalized concept, broad concept, whether a single unit or 2 units, and reconstruct the 3-dimensional bone so that we can place implants ideally. Today we think a lot more really about the knowledge that we've accumulated over the years and how do we put it together as clinicians. And in fact, this concept is what inspired the outline and the foundation of the program that you have before you. It's looking at interfaces. Today, in implant dentistry and aesthetic dentistry, we think about interfaces. Some of them in the area where the implant is placed relative to the bone, some of it at the connection, as you've heard today, and over the next few hours and tomorrow, also the area outside within the oral environment as well. So we break down interfaces, and we approach treatment planning in our practice, at least, in terms of interface developments. No longer implant site development, but actually down to the level of the biology of the system, the biomechanical aspects of the system. And we break it down to surgical biology and restorative dentistry. And in many ways, if you look at your program, that's really how the program is set up. You've seen earlier today talk about macrogeometry and microgeometry. We talk about bone grafting, the relationship of what type of bone we want to graft with. We talk about also soft tissue. How about what kind of soft tissue thickness and quality that you put over that bone grafts and over the implant that you place in this area. So we break it down into that surgical phase. We'll talk about the biology of the interface, which certainly has been discussed quite a bit this morning, and then eventually that area where the restoration goes out of the soft tissue and into the mouth, and what kind of aesthetic relationship that we deal with. My area in the next few minutes is really just that area of the connection and how we relate the abutment to the implant and try to do it and develop it and deliver it to the patient at the first time of implant placement, or at least uncovering. In ideal sites today, it's pretty straightforward. You've seen beautiful examples of that. We can do incisionless implant placement and develop areas that we can achieve quite high aesthetics. But what hasn't really been discussed is also the fact that there are failures as well. And these failures can be looked at less in the generalized term, but we can break it down very specifically that there are labial failures of recession and color changes, as well as interproximal failures. They're not the same. They're not caused by the same factors. And as clinicians, we need to be able to address both of them and factor them into our treatment planning process. So when we look at a relatively simple case, agenesis of lateral incisors that have been replaced with implants, patient comes into our office a year later, 19 years old, the mother's telling us that the tissue is getting darker over time. Most of us can think about it that really for most factors, forget about the ceramic shade matching, but they've matched the level of the gingival margin, they've matched the height of the papilla. Those are within the scopes that we would really judge as being successful. What's not successful is tissue color. So from that perspective and looking at implant and recipient sites in these particular restorations, the failure here was not one of technical application of treatment. It was one of really diagnosis and developing treatment plans to address the diagnosis of that particular failure. This was agenesis, so you had concavities here. So in many ways, this was a labial defect. The bone never really developed into a type 1 ridge, but it was treated as a type 1 site with minimally invasive implant dentistry. And minimally invasive implant dentistry works best in type 1 sites, where we can preserve that site, where we don't need to augment it. But when you already have a type 2 site, that really requires that we develop it back into a type 1, which would require augmentation procedures. When you lift the flap, you can see the die back to the first thread, which Dietmar discussed a minute ago, and certainly typical, especially with external hex implants. We can all think about why that happens. You put the implant in, thin labial plate of bone, as you see here, no perforation, you have an intact osteotomy, you can place your implant and expect that that labial bone, at least back in the early 90s when this implant was done, that that bone would actually remain. But we all know that once you put in an abutment, as you've seen, that bone dies back, and you've seen much better examples of this earlier. What we can do today is change that relationship. Some of it can be done with componentry. The rest of it can be done by thinking about how these interfaces really relate to each other. One factor is what happens when you only have 1 millimeter of bone. That may be enough, as Dietmar said, with a lower incisor or with a natural tooth. It may be enough, as you've seen on cone beam technology, on an implant. But how does that relate to maintaining buccal lingual width of an implant site relative to adjacent natural dentition? Of maintaining concavities, convexities of root eminence in those particular areas. So this is only one part of the puzzle for us. In interface development, when we're dealing with thin bone today, we also think about grafting outside that thin bone, usually with a slow resorbing material, such as bios. And we always, if we raise a flap in the anterior region today, especially with thin tissue, we put in a connective tissue graft. That's a very big component of our protocol to overcorrect, especially challenging thin tissue types in the aesthetic zone. And for this correction for this patient, this is really what happened. We took a concave environment and created harmony with the adjacent dentition and adjacent profiles of the adjacent teeth with this connective tissue graft. Thick tissue, usually we take it, it's dense from the tuberosity area, and it allows us to give us good color stability and good dimensional stability over a period of time. Another factor which becomes very critical, and based on the literature now by Ronald Jung from Switzerland, is talking about how that tissue stability is important relative to thickness and how it relates to actually how we make decisions about abutments. And in a very interesting and very really simple study, they compared, Ronald compared ceramic abutments with metal ceramo abutments ceramo metal abutments in terms of what color changes they imbued on the tissue relative to the thickness that's available. And they did it on the same tooth, and they compared the tissue color on the ceramic abutment versus ceramo metal and compared it to the adjacent tooth. And when does it become something that we can actually measure? And they did this with a spectrometer, and when the tissue is greater than 2 millimeters of thickness, it really didn't matter whether you had an all ceramic abutment or a ceramo metal abutment, relative to being able to see color changes. When that tissue was less than 2 millimeters, you can start to actually objectively measure changes in color between a ceramic and a metal abutment. So the first thing that we can tell you from an interface standpoint is, as clinicians, ceramic abutment may not be that important if you have more than 2 millimeters of thickness. So color issues and thickness of the tissue become very, very important. And you can see in this case, a kind of save just by changing the thickness. Nothing else, the same implant. There was no bone grafting. Just by changing the thickness of the tissue, we were able to change the way that tissue and these crowns are displayed in the mouth. And they have a much better shape as well because they're coming out of a normal dimensional tissue. And you can compare the original with the redone case on the right side. So when we talk about all these components, and even when we talk about one abutment one time, all of these remain as only parts of a bigger story of integrating interface development into treatment planning. And tissue thickness and grafting, and including that, is also a factor. There are many reasons out there today, and certainly in the literature, that relate to why we as clinicians get some failures in our practice. Why do we get recession? Why do we get color changes? One of them is natural post-extraction resorption. Whether you believe bundle bone has a great role in it, whether it plays a partial role, and whether it differs from thin scallop tissue versus thick, flat tissue is one factor that plays a role. Traumatic extraction, full thickness flaps, certainly something to consider. That's why whenever possible we try to do incisional displacement, especially in type 1 sites with thick tissue. Inadequate thickness of the labial plate. Inadequate thickness of soft tissue, which I just mentioned relate to stability of tissue color. Inadequate grafting of the extraction sites. Excessive buccal placement of the implant, we also mentioned earlier this morning. Inadequate connection and microgap and the biologic width effect that relates to that. Over contour of the emergence profile, leaving the implant in the subgingival area. Very, very big topics. And of course, my topic, multiple removal and replacement of components, which keeps damaging the interface, especially the junctional epithelium and so forth. So all of these are very, very important components, and you can see how many of them there are. We as clinicians can minimize the effect that these factors have on our particular specific implant on that specific patient. Some of it we can change by some of the techniques we utilize surgically, others by choosing different macro geometry for an implant, a different connection. And certainly some are on the restorative level of minimizing the over-contouring of subgingival profiles and the multiple removals of components. That's the restorative. And you can see that it follows from the surgery to the restorative, and it's the planning that plays a really, really big role in that. So when we bring it to applying it on an everyday basis and being able to really utilize it in an efficient process, you can see a situation like this, a tooth that's fractured at the post, there's a little lesion here on the mesial of the tooth. How do we actually protect this very, very thin labial plate of bone? How do we treatment plan it so that it becomes a part of the protocol and the practice that can be reproducible and very, very efficient to us in an everyday type of practice environment? We use a lot of CT technology today because it's so readily available, especially with cone beam availability. And we can actually, in many ways, in some of the software, remove the tooth even before we actually do it clinically and try to put in our implants in ways that follow this concept of interface development that we just talked about. What are we trying to do? Not stress the labial plate by using the triangle of bone, a concept that was developed in the mid-90s by Scott Gans, which tells us to use that palatal bone more and leave some space, a millimeter or so, between the implant on the labial and the socket wall. I want to end up about 2 millimeters from the implant on the labial surface to the outside of the bone. All of this can be done on your software. And then take that information, send it out. You can get surgical stents. And you can actually take that surgical stent, have your laboratory technician place an implant analog on your model using the surgical stent. And so this is something the restorative dentist can do with the laboratory technician. There are many different ways of applying this technique. And they can fabricate using Radica here from Dentsply, a composite, Licure composite resin that's utilized for provisional fabrication. And literally either create a refractory die that can be utilized later on so that once the abutment is placed, it never has to be removed. We can work on subgingival contour. We can work on overall relationship. And all of this is based and done prior to the patient even walking in for the extraction and the implant placement. We can make decisions about materials, whether you're going to use a ceramo-metal abutment or a ceramic abutment. A lot of these and many of these decisions are actually now capable of being done outside the mouth and prior to getting in there clinically. So instead of using chair time, all of the decisions, what implant to use, what diameter, what abutment, how long is it going to take me to fabricate a temporary restoration, all of these factors can be done ahead of time. You can use the same process and actually put in an analog directly into the stereolithic model that you utilize. The laboratory technician would then utilize the abutment, choose a final abutment, and instead of having to utilize and create a custom abutment, the great thing now is dive and ankylose. You have pre-contoured anatomic machined abutments in ceramic and metal that they can utilize, fabricate a coping and a temporary restoration. So when you walk in there on the day of surgery, all of the components are available to you, and if you choose to put in and you have enough primary stability and you make all the decisions of whether you want to use immediate provisionalization, all these components are done. So in this particular case, the tooth is extracted. We graft both bone inside the socket and outside the socket without raising a flap. Sometimes, if it's thin tissue, we'll add a connective tissue graft and put in the abutment that was initially chosen by the laboratory technician with the idea of not having to remove it again. And this concept was the term first used in the 2001, and the provisional is fabricated. And the issue for this particular case, and I show it to you, this was actually done where David and I placed a treatment plan and placed the implant in Atlanta. Maurice was in Austria, and we did it through a satellite link. He basically talked the audience through as watching us putting in the implant and temporizing. And literally everything was ready, as you can see here, the abutment, the temporary restoration, fabricated ahead of time. And not that the time is a factor, just as an example, it literally took 22 minutes to extract the tooth, place the implant, the temporary, and luckily we had Maurice on the podium because he can talk about anything. And even though we were finished in 22 minutes, he was able to take the program all the way up to an hour. But it just shows that today with the tools that we have, and when we start to think about interface development and really taking us through it, and with the components that we have, we're able to do a lot of these in a much more efficient and predictable fashion. Look at the tissue on the adjacent tooth, and now the tissue about 8 weeks later on the temporary restoration. We may have lost just the hair on the buccal, but that's why we graft the areas, and that's why with thin tissue you actually have to include a connective tissue graft. But we were able to maintain most of them, preserve that site. Here's the temporary removed. The laboratory had fabricated for us a transfer coping made out of zircon with a notch here. This was prior to being what we have available to us today, which is really the best way is to have snap-on components. I won't get into it today because that's really the topic for Barry Goldenberg. He's going to talk to you about snap-on abutments, that you can use snap-on components without ever having to remove the restorative abutment, and how friendly that is to the tissue, which is really part and parcel of this approach of one abutment, one time, not disturbing the tissue, not disturbing the junctional epithelium in these areas. What will happen is the ceramist will then cut off this notch and this area that's used to pick up the impression, and then literally layer on his ceramics on top of that. When we factor in a lot of the concepts, we want to have a flat or concave emergence profile in our restorations. Marco De Gidi earlier this morning told you about creating space and not overstressing not only the labial bone and implant placement, but we don't want to overstress the soft tissue. And those are all critical components of that. So we try to have, and we've been doing this since the mid-90s, of having very flat or concave emergence profile, both in the abutment and in the eventual crown, depending on the tissue type and thickness that we're working in. And you can see the temporary here, the final restoration. And when we compare it with the original, this is the original temporary after extraction and implant placement, the final restoration, we pretty much were able to preserve the environment in a very efficient and very predictable manner, utilizing these techniques early on and post-op x-rays. And when we talk about today, it's not enough to talk about the stability of the bone around the implants, not only mesial and distal and labial, but also we need to talk about soft tissue. The thickness of the soft tissue, not just the height that we're able to maintain, but also the thickness, and how important that is to overall aesthetics, and to have created a little bit of a redundancy to secure the stability of your tissue, not only levels, but also color over a period of time. All of those interfaces have to be part of the equation that we deal with. So when a lot of the material that you've seen, and obviously in a short period of time that we can talk about, a lot of the material can be found for you, and many of you know of the site already. This is a web dental community, if you will, where many teachers and clinicians get on to share ideas and concepts, ask questions, share challenges with each other. But also it's a dental web learning site, and we ask many of you to participate and put material on here as lectures or videos, and share those with the rest of the dental communities, www.dentalxp.com, and we invite you to be part of that in any fashion that you would like. But the critical aspects for us is to really think in terms of interfaces, think in terms of how we put some of these components together, and the components that come as pre-contoured abutments, when we're talking about the ankylose in particular, that subgingival concavities that are involved, or under-contoured environment that create space for connective tissue grafting and thickness, are built into the ankylose system, which is why we're very excited about it, and actually we'll be even more excited once the indexing comes into play, because certainly, at least in the US, an index system is much more comfortable for most of us. So having the extra space and the under-contoured emergence profile that's built into the ankylose system, I think is a very big benefit from an interface relationship that we work in, and it allows to create that extra thickness in that very critical area at the crest of the bone. So taking all of these factors together in interface development, we talk about platform switching, bacterial-proof connection. You've seen that and heard about that today. No micro movement, subcrestal implant placement, micro roughness to the surface. All of these are important components, but they're part of a larger picture that we have to really put together and integrate together into aesthetic dentistry. And one abutment, one time, if we can actually get that abutment in, either, as Dietmar showed you, either at the time of implant placement, so in a non-submerged immediate environment, or even after you've created a type 1 site through augmentation, take a type 2, changing it to a type 1, and come back at a stage 2 environment. Try to have an abutment ready to be able to be placed, to be able to not disturb it over a period of time, I think is another very critical interface that is built into all of these factors of taking care of that tissue, taking care of that stability. And I think it's a concept that's very important, and certainly will lead for us to continue to create that, those interfaces that create the kind of success that we're looking for. So thank you very much for allowing me to participate in this podium.